and transgender psychology with specialist knowledge in, but not exclusively, mental health and physical health in LGBT. So we are very excited to hear her talk, and yeah, so hopefully there shouldn't be any problems this time. Hello?
Hi, I'm here. Can you hear me okay?
Yeah, I can hear you, can see you, it's all good.
Oh, that's perfect. So I'm now going to have a go at sharing my slides, which hopefully someone will let me know if you can see those.
Yeah, looks great.
How's that? Great. Okay. So thank you. First of all, thank you so much for inviting me today. I'm really, really pleased to be here, especially as of course this was arranged for quite some time ago and has now been rearranged due to recent events. I can't think what's been going on for the last year. Can't remember. So you can see the title of my talk, and I'm going to talk through a series of slides, and I know that I have a 45-minute slot. I might talk most of that time, and if we don't get a chance for many questions, you're going to have lots of opportunities to be in touch with me. So I'm on Twitter, and actually my email address isn't on that first slide, but someone could put it in the chat for people. I'd love to hear from you. So who am I? I'm a psychologist. As you heard, I've been working in LGBT health research for about 18 years now, specifically focusing on health inequalities. I'm a psychologist. I also work here at UEA as an associate professor, and I'm also the lead for diversity and inclusion in Norwich Medical School. That's my Twitter on the left. And if you have a QR code reader on your phone, you can take a link through that QR code to all of my research papers. And I make a point of publishing open access where possible, which is something that I believe in, that is very important to disseminate and share findings. What am I going to do today? I'm going to give you an understanding of the specificity of LGBT plus mental health inequalities. I'm going to present available evidence of UK mental health inequalities. I'm going to highlight gaps. I'm also going to touch on exploring pathways to poorer mental health in this population, and I'm going to make a series of recommendations to reduce these inequalities. And I want to start with some brief notes on labels and initialisms. Okay, so LGBT, LGBTQ, etc., they are a set of initials. So the grouping of that is not an acronym, it's an initialism. I'm saying that because there are multiple sets of initials. They've got historical and political fluidity. Things have changed over time, will continue to change, I'm sure. They this term LGBT Q plus that was given to me for my talk encapsulates sexual orientation, identity and gender identity. They also, of course, encapsulate sex. So there's quite complex issues here. So in my talk today, I'm going to make reference to LGBTQ plus, LGBT plus. You're also going to see me mention LGBT, LGBO and LGB. These are not a mistake. These are very, very specific and intentional. To draw your attention, LGBT would be very specifically when I'm talking about people who have chosen to identify as L or G or B or T for trans in that. LGBO is very important to point out because of the research that I've done using available population level data. I have incorporated the initial O for other, which is an identity that's chosen at a point, and you'll come see that on a slide later. And quite a lot of the work that I'm going to be presenting to you will be using the LGB initialism, which is to incorporate sexual orientation identity, which is where most of my research has taken place for reasons that will become clear. So I've been certainly giving talks at least a decade, if not certainly longer, but for about a decade, I've probably put this slide up It's varied slightly over time, as you can see by the dates, but ultimately it has stayed pretty much the same. And it's because I like to start by telling an audience, and I suspect you're a very intelligent, well-informed audience, but just in case there are people in the space who are listening that perhaps don't understand why LGBT mental health is so important, well, perhaps we should be thinking about who's the population, right? So I always start with this slide, numbers of UK LGBT, and I could actually put up a blank slide. I could put up a blank slide because we don't know. We don't know because we don't ask. We've never asked. Well, until very recently, which is very exciting. And if I could see you all, I'd hope to see lots of lit up, sparkling faces because you're excited by the fact that there's some hot off the press news, or you may be, as I say, very informed and understand where I'm getting at, what I'm getting at with that statement. So, nevertheless, I do have some bullet points to share, and they are all, though, estimates. And this is a real shame and very problematic, very significant. And if all I was to say to you today is, well, just imagine the fact that you're not being counted, then why would somebody whose identity is never counted feel as if they were perhaps an equal part of society, right? Nevertheless, we have some emerging estimate data. Back in 2003, there was a sort of a 5 to 7% sort of suggestion, again, an estimate. We do have some data from the GP survey, which is an England-only survey, which has collected some sexual orientation data, and that gives us an idea from those who answered. We have a 2% LGB group rising to 4% in London, so maybe 2 to 4%. GIRES have indicated a level of gender variance in the population at around 1%. The most helpful thing we have was a modelled estimate by Public Health England that was based on all recorded responses to UK surveys, which they pulled, and they put forward a weighted estimate of around 2.5%. But notice the range goes up to as high as 5.52%. This is important because what we know depends on how we ask it, because if you ask face to face, then you may well get very different levels of response than if you ask someone to respond online or written for reasons to do with oppression and fear of disclosure. And it will also depend on how you word the question. What is it that you're asking? So if we're thinking about sexual orientation, are you asking somebody whether they have same-sex attraction, whether they have same-sex identity, they carry out same-sex behavior, or whether their own sexual orientation identity is that which is being asked? And there is variation within here, with greater numbers to the left of that list and smaller numbers to the right, which is to do with fluidity, etc., etc. But we can come back to that. So another sort of helpful indication about sexual orientation identity estimates comes from the annual population survey, which has been asking about sexual orientation since around 2014. And this is a really interesting graph with some points that I want to draw your attention to, because it shows that the number of people who are identifying as heterosexual or straight has been reducing over time, and the numbers of people choosing gay, lesbian, bisexual, other has increased over time. So that's one shift. The other thing, of course, as you note there, is that on the bullet points I point out that there are an increase in numbers of people who therefore have been identifying as LGBT between 2014 and 2018. And there are figures that talk about 1.6% to 2.2%, which is fair enough. But have a look at the bottom line of that graph. 2.8 to 2.5% of the population are not answering that question, or choosing do not know. And that's important because this is to do with the identity, choosing fixed identities, labels, etc. This is a really, really important issue, and basically underpins a huge amount of work. And I'm giving a talk on this very topic in June, sort of after many years of working in this field. So some very interesting issues here about identity and about measurement. And I just want to flag that this underpins a huge amount of what I'm about to present to you today, is the fact that we ask these questions, and we ask the questions in this way. This is very important. Whereas I do understand fully that there are lots of sociological, cultural, and multiple other personal reasons and for people as to why these labels may feel limiting or limited. Nevertheless, it shows us very important data, and data is, I'm all about data. So this graph shows you that this change in self-identified sexual orientation, it's very clear where the 0.0 is a line that marks no change, and everything to the right is an increase, and to the left is a decrease. So that's basically the same piece of information as the previous slide, but displayed differently. If you're interested, there's a link on this slide, and you will be getting these slides, which will take you to a full exploration of all of the data around this annual population survey. Were you interested? Now, if you remember a little bit earlier, I mentioned that something had changed recently. Well, for the last, certainly, this is definitely for the last decade, I get to that slide with the findings on it, the numbers on it, this one here, and I jumped straight to this slide, and oops, there's a bit of a delay, sorry, that might change. Oh no, it stopped, good. I get to this slide and I say census 2021, and I put or census usually with an exclamation mark, and I say we should be asking this question. So anyway, after 10 years of asking, they included the question on sexual orientation and gender identity, shortened here to SOGI or SOGI. It's slightly a North American term, but I find it very useful for shortcutting and to allowing us to distance ourselves from the initialisms such as LGBT, where there are multiple ways in which people choose not to identify under the headings of SO and GI. But for this data, I'm going to use SOGI. So we have now got a very real opportunity to establish the size of the population, assuming the data that was collected meaningfully, and that was filled in meaningfully, because of course there was a last minute change around the questions on gender identity and sex. So and people choosing their own self identity. So depending on that, whether that last minute change gives us meaningful data, we have a very real opportunity to establish the size of the population, and I for one will be very pleased to see that. So let me give you tell you a little story. So a little while ago, I was asked to give a talk around the impact of COVID-19 on LGBT. I think this is a very understandable question, very interesting, very important. And I was very happy to do that. So I decided to collect some evidence together, which is of course what I would do. So I went to Public Health England's paperwork, which is fantastic, of course, and there's a brilliant document on disparities in the risks and outcomes of COVID-19. And there's your content page, fantastic, all the protected characteristics. Oh no, I can't see sexual orientation there. Oh, okay, not to worry, I'll do a search. Sometimes it gets called something else. So I popped in my classic search and popped in lesbian, which is what I bet to find in a disparity document. And anyone that knows, that red box means no data. So the disparities document from Public Health England didn't include anything. I thought, oh, okay, that's interesting, / not that surprising. Because the thing is, we're not measuring LGBT identity in many places. And measurement really matters, because then we have data. Because we could answer the question, how many LGBT people tested positive? How many died? How many have been vaccinated? How have LGBT people been affected? I could bring you data today about LGBT people, COVID and mental health. I'd love to have done that for you today, but I don't have any data, because we don't ask for sexual orientation and gender identity standard. Recording of sexual orientation identity and gender identity or gender reassignment, I should say, as a protected characteristic, is necessary to allow monitoring, okay, for public health reasons. I mean, that's how we are able to send resources to where they're needed, because we find out where the needs are, because we ask. But we're not asking. And the other reason, of course, is that recording it is necessary to comply with the UK Equal Opportunities legislation, which is the Equalities Act 2010. So actually, if we're not collecting it, we're not complying. Why is measurement so important? Measurement allows us to capture evidence, and evidence is what underpins policy and funding for interventions. Okay, so that's my setting the scene. Here's that QR code again, if you'd like to take a grab of that, and you can have a look at the research that I'm going to be covering today. So I am going to be able to present you with some research findings today, and this is an important set of data because, as I said, evidence is what underpins policy and funding, and there is some evidence to share. My work is around the relationship mostly with sexual orientation identity for reasons that will or are becoming perhaps evident to you, which is I analyse what is available. I'll come back to that. The model that I look at is obviously through minority stress having an impact in terms of, and I look at physical health and health behaviours and mental health. And today I'm going to talk to, and eventually, ultimately, those in their relation to impact on mortality. But this model, what I'm focusing on today is this part of that model. So let me go back historically to the very first systematic review that was published around mental health and lesbian, gay, and bisexual population. So this systematic review looked at all existing papers that were available around sexual orientation identity, and it found that there was increased prevalence of poor mental health in LGBT people compared to heterosexuals. This is now a hugely highly cited systematic review because it demonstrated at the highest level of evidence, which is a systematic review, that there is a disparity in mental health between sexual minorities and heterosexual population. Importantly, that showed that increased mental disorder is across a multiple range of outcomes and issues. So we have much higher levels of suicide attempts in this group. Across LGB was 2 times increased risk, but in men, in gay and bisexual men, that's up to 5 times higher. So 5 times higher gay and bisexual men than compared to heterosexual men. Suicide ideation was 2 times higher risk. We have higher levels of alcohol dependence, drug dependence, depression, and anxiety. The research that was pulled was of existing available research, most of which had a USA population. That's an important point. We did a second systematic review looking at counselling and psychotherapy and found some really interesting findings that I just want to draw your attention to as well. And that is that the research, the collating of the findings showed us that therapists make heterosexual, as you would understand the phrase, I'm sure, heteronormative, the assumption that you are heterosexual as a client, which means that you have an option as a patient to come out or not come out. Lots of people talked about having concerns about actual feeling safe to come out. There were preferences for having a therapist who was themselves an LGBT identified person. There was concerns about a lack of knowledge in the LGBT therapists. And really importantly, what came out of this research was that there is a tendency for a misattribution of the presenting problem to be in relation to that person's LGBT or T identity, rather than in fact the problem that they arrived with. Another finding I just want to flag up that didn't come from this review, but I want to mention it just now before I move on with the rest of my talk, is that, and this has come up already today, and I've been listening to what's been said in the conference today, and been listening and reading a lot of research over the last few years that is showing that one of the ways that the barriers can be overcome is that using informal sources of help seems to be very common for LGBT people. And is this, this is the use of the internet is a really important source. Also, people are choosing to talk to family and friends rather than NHS or school or perhaps university-based mental health services. And I was thinking about that in relation to some of the things that were being said earlier about accessing services, and although there's already sort of stigma and anxiety about coming forward, and then if there's an anxiety that you're not going to be taken seriously, or that the assumption that the reason that you're upset is not about the loss of your cat, but about the fact that the assumption is going to be that that's something to do with your sexual orientation or your gender identity, then that's going to prevent people taking up services, and that's really important, isn't it? So let's just just plant that there for the moment. Okay, so as I said, I'm going to present you now with some UK evidence. So what happened was around 2008 onwards, a series of national health surveys that have been collecting data for years across the population of the UK and across multiple demographics such as ethnicity and age, finally got over themselves and started asking a question about sexual orientation identity. They did not and currently do not ask about gender identity. So I will not be presenting that data. That is why my data is on sexual orientation. We used individual participant meta-analysis to pool estimate each study, grouping those studies therefore together, and allowing us to have a much larger analytic sample, giving us enough statistical power to be able to compare not just across heterosexual versus non-heterosexual, which is commonly found in research because of sample sizes. Our sample size was big enough that we were, as you can see, nearly 95,000 participants. You can see the breakdown of those identities, and we were able to compare across disaggregated identities within that initialism group. And so what we found was that in the UK population, lesbian and gay people have higher levels of mental health disorder than heterosexuals, that this is over 2 times higher, but that there is some variation in the way that's presented in age groups. So there are slightly higher levels, and this was significant, this finding, for under 35s and over 55s. In the age group 35 to 54.9, that was, although higher, 1.48 versus 1, was not significant finding. For bisexuals, this was both higher than heterosexuals, but also higher than lesbian and gay populations. So again, you can see that there is a higher risk in both under 35s and over 55s. And again, although higher was not significant in the 35 to 55s. So that would be called common mental disorder, which is things like anxiety, depression, lots of the things that you've been talking about today that we understand as mental health. I also think it's important to include smoking and alcohol, actually, as part of poorer mental health in a broader sense, because actually higher numbers of people with poorer mental health smoke and use alcohol more. That's one thing, but also if we've got high rates of poor mental health in sexual minorities, then it's also important for us to have a look at the ways in which they are coping and managing their mental health. And smoking and alcohol are very significant ways in which people choose to try and cope with the stress and the difficulties they're experiencing in life. So this slide will show you that you are 2 times more likely to have a history of cigarette smoking if you're LGBT than heterosexual by the age of 18 or 19. And that lesbian and gay population are nearly twice as likely to report drinking alcohol more than twice a week, and more likely to report binge drinking more often than heterosexuals. So we also find that. There was mentioned that I also look at other physical health outcomes, but I won't be presenting any more on that. But that link I sent you will show you some other findings that I have looked at in terms of physical health. I want to make a couple of points about kind of intersectionality, actually, and it's really interesting, the talk that was before lunch around Islamophobia. It's very powerful talk. It's very interesting because, of course, the way that you've asked us to speak today, and that's completely understandable, is that there was a talk on Islamophobia, and then there's a talk on LGBT, but actually people who are LGBT are also Muslim, and people who are Muslim are LGBT, as an example, and multiple other intersectionalities. So I wanted to share this paper with you because it was so interesting that this study was looking at P practices and gay Muslim men. And what came out of this study was really, really powerful and would have very significant impacts on mental health when there is a realization that it was almost impossible, if not impossible, for the population in this study, this was a qualitative study, so it's not a population of a study, but the sample, I should say, in this study, basically presented that it was impossible to be both homosexual and gay and Muslim. So as an example here, you have a quote. One of the things he said was, "Don't worry, as soon as you find another woman, your homosexuality will be cured." He couldn't believe I was gay. He said, "I was a Muslim, I couldn't be gay." So this is really important as we're thinking about our populations here. I want to highlight for you that there are multiple intersectionalities within this population that I'm presenting to you. And this is an example of a way in which somebody might find it almost impossible, perhaps, to seek any mental health support if they have a history of experiencing barriers within their own experiences with health professionals. And it touches on this concept of disclosure and why fearing disclosure is a reason why people don't come forward for treatments. So it shows that intersecting identities can combine to amplify health inequalities. So here's an example of a group who are facing inequalities associated with other members of the Muslim communities, as per the talk you heard earlier, but in addition, they face inequalities experienced by other gay men. So, as I said, there's a thinking about disclosure here. Another thing I want to mention here is when we think about mental health, we often talk about common mental disorder, as I've presented, but I also want to flag up dementia here, because this is a really interesting complex topic where dementia, as an example, might be where somebody becomes quite fragmented cognitively, and things start to break down for that person. And if that person has a lived experience, perhaps as closet, especially in our older population, as a closeted gay man, or perhaps somebody who is living in a with a trans identity, that entering the kind of care home situation that you might experience as somebody with dementia would have, or entering that kind of cognitive decline, may put that person at risk in multiple ways. And I'm just flagging that. It's a very complex issue. So I could do a whole talk, and have done a whole talk on it in the past, but let's think about marginalization here. When I talked about intersectionality in the previous slide about being Muslim and both gay, in this instance, perhaps you have a marginalization across a triple identities, both sexuality, for example, a cognitive decline, and age. So it's another example of intersectionality. Okay, so I've spent an awful lot of time talking about sexual orientation for reasons that I actively analyse population data, and because it is the highest level of evidence available to us, which can be used to influence policy. And my reason for not presenting you with any gender identity health outcomes is that nobody collects at the moment gender identity at all in any way with health surveys. The census has included a question on gender identity. This has been designed now in connection with the Office for National Statistics, who helped design the question on sexual orientation. So I expect to see changes, and there will be changes moving forwards, and I will be analysing that. But I wanted to make the point that it is no surprise, I'm sure, to this well-informed audience that trans people experience huge levels of mental distress. And I wanted to share you with a study that took place in the UK, although it's not a population study, had around 900 respondents with huge levels of mental distress. And this is very important because, of course, as we think about moving forwards, if we use our data to impact on policy, then we need trans data to be recorded in surveys to allow us the same high quality evidence. Because as an example of what evidence impacts on policy, the very first systematic review I showed you, I'm not going to risk flicking back through the slides, but that first systematic review from 2008, because of those findings, the National Suicide Strategy was amended to include sexual minorities as a high-risk group within that policy. And that change therefore led to the possibility that that group are recognised as needing particular targeted help. So there's evidence for you that evidence in this level impacts in very significant ways. And this is really where my work has been focused for the last decade or so. As a passing slide, which I'm not going to spend time on because of the time that I've got, I've included this and you're going to get the slides. I did pull together some very significant points about COVID, LGBT and mental health. I think really COVID has highlighted significant the impact of things like social isolation in this population. Also, the huge levels of domestic violence that's experienced by LGBT people. Again, kind of known, but not hugely known out there in terms of evidence, but it's there is a growing body of evidence to demonstrate that is the case. So people have been trapped at home with violent partners, but they've also been stuck at home with unsupportive parents, people who are younger people going through transition, or younger people exploring their sexuality who feel safe when they're with other LGBT people, who were then forced back into their homes over the last year, potentially in either at best unsupportive and at worst extremely frightening environments. Remember, a large number of homeless people are LGBT youth who have felt unsupported at best and indeed forced out of their homes at worst. We think around 1 in 4 of the homeless population constitutes this group. So one can only imagine the experiences that have gone on for people over the last year. Most of the services lost their funding. Lots of services had to close down. There has been talk about moving those services online. And whilst you'd agree that that's probably maybe not necessarily the best way to provide services, actually being able to access any kind of confidential support in great crisis is a great thing. So there's been lots and lots of ways in which mental health has been impacted in the last year. So I want to come to this question because what I've presented you up until now, kind of what are called cross-sectional surveys, they're a capture of a point in time. And what I wanted to be able to answer is the level of mental health, the impoverished mental health amount in LGB people, is this improving? So it's possible for us to answer that question now. And that is a paper that came out this year with 10,000 participants. Half were from 2007 and half were from 2014. And we found very high levels of similar to the previous research I've shown you. High levels of depression and anxiety amongst bisexual people was as high as 40%, 28% in lesbian and gay people. Illicit drug use, again, high, and alcohol misuse high. So this is findings that are familiar to us. But what was novel, and why I've entitled this slide Enduring, is that in this analysis, the researchers, we found that there'd been no change, i.e. no improvement between 2007 and 2014, with LGBT people remaining at higher risk of poor mental health when compared to heterosexuals over this time. And I think this is important because I think as a society that there has been some shift in terms of perhaps inclusion or perhaps raised awareness. And it'd be really interesting to hear your thoughts, but has there been any really significant shift in terms of societal acceptance? One wonders. And certainly this evidence tells us that for LGBT people, that shift for them as an internal reaction to the external stresses and stigma appears to be unchanged. So very briefly, again, you have access to these slides. Let me make just 2 or 3 points across a series of slides. Firstly, why is this the case? Well, if you grow up as an L or G or B or T individual in an intolerant society, one that preferences and prioritizes heterosexuality and cisgender identity, perhaps that might make a lot of sense as to why you develop a sense of not feeling as if you are included, welcome at best. But actually people are experiencing actual and very real stigma, discrimination and prejudice throughout. Remember, coming out is something that happens all the time. Every new job, every new encounter, one has to navigate. Will they accept me? Will these people accept me? Will I be accepted this time? Every time. So the stress never goes away. Yeah. There isn't just that single moment. Oh, I got through that. It's okay. One has to come out repeatedly. There's a few other points there about health professionals and in a health context, about the fact that LGBT activity is centered around clubs and pubs because they're the safe spaces that have been created, where they focus on alcohol and drug use as an example. So there's lots of kind of exacerbating factors. This here is a theoretical summary of the minority stress theory that I've just touched on anyway, for those that are interested in theoretical models, perhaps to try and understand the pathway. Here are lots and lots of stressors that you could think about likely to be having their impact. And here are 2 or 3 calls to action I would like to make. Firstly, that sexual orientation, and once we have an agreed question, gender identity, is collected as standard. That is, in every survey, in studies. Why are we not asking that? We ask ethnicity and age and sex in almost every study we ever do. We're able to disaggregate those findings by all of those demographics, but we're not asking sexual orientation and gender identity. And so we're never finding out anything about this group. And a couple of points about recommendations because of time. I want to make some points about what we should be doing in terms of practice. We need to provide LGBT friendly health services. Okay, so that's the way we practice, that our context, we provide the environment for sure. We need to think about developing interventions that address discrimination, that increase resilience and reduce impact on LGBT people. When we are designing both of these, we need to draw on LGBT people's own expertise. Yeah. Think about the provision of community services, think about the use of local organizations, And LGBT people have their own lived experience, expertise, and that's what we should be drawing on. I want to make a point about training. Yes, we should be training better, more often. All that said, all those good things that I have on my slide, as a take-home message, this training needs to be not optional, not the LGBT session or not the diversity session, but that this teaching needs to be embedded and integrated within mainstream teaching. In this regard, I'm talking medical teaching, but indeed any teaching and training, nursing, etc. No one-off diversity session as a tick box. And I'll just finish this quote. This is from, it was actually a Stonewall survey, I think, but I just think this is so important. You know, I don't believe I have equal access to appropriate healthcare services as my heterosexual counterparts. So not only do we have lived experience of high stressors, we also have reduced access, inequality in access to healthcare services. So thank you. Couple of points to make. I have a book coming out around LGBT mental health next year. There's also a special issue journal that's going to come out later on this year. That's my email address. My Twitter account. Again, that's the link to the papers. And I am going to just flag up, I would love to find a research intern, as I've got 2 or 3 unfinished studies. And if anyone's interested, drop me a line.
Thank you very much for that. It was really interesting. There are a couple questions. We have about 5 minutes. So first, I think there was something about students and how if there's any study that highlights the difference between LGBTQ students and people from similar age that aren't actually studying, if that makes a difference at all.
I'm just reading the question. Whether
Yeah.
I think it's easier if I read it, if that's okay.
Yeah,
The findings track with students. I know there's a lack of studies on students, but if any, no, not population level. There isn't. There is, of course, there are findings that talk about younger people, but no comparison between students versus other age groups. That's quite an interesting idea, Amy. I'd love to bounce it straight back to you and say, why do you think there would be a difference? What would you expect to find? Do you want to jump in, Amy, and tell me why you asked that? Oh, does she have sound?
No, I think they can only.
Sorry, Amy.
So she might be able to answer, but it might take a while for her to type.
No, it's fine. I just suddenly realised it's collaborate, isn't it? So yeah, I'd be really interested to understand your thinking. I love questions that kind of unpick differences and what might be going on. But yeah, shall I read on what's in front of me, Gaia?
Yeah, sure. It's probably easier. Yeah.
We've seen the younger people. The older generation seem to be more. How can we target the older? How can we target the older people to stop these phobias? Again, I'll throw that out to you. I mean, I think one of the problems is it's about history and it's about context. And so I think that there is a shift now in younger people are just fantastic. It was so different back in the day for me. Looking for role models, looking for people that were like me, and not really finding anybody. So I think part of that is historical, to do with history and to do with context. I also think I have reached a point in my life where I have realized that you're not always going to change everybody. And sometimes we're better off using our energies in much more positive ways than actually trying to change every single person's mind. Brilliant. As a researcher, I found that often the prefer not to say option is selected a lot when asking about sexuality. How can researchers? That's fantastic. Okay, that is, I've got an hour-long answer to that. But in a nutshell, I think we shouldn't include prefer not to say. The reason that I've been able to make any changes and do any of the work that I've done is because of this standard question that's asked. And whilst I'm happy to engage fully in the discussions about how limiting it is to force yourself to tick a box that doesn't really represent you. Those are the data we have. That's the question that's asked in multiple surveys. And by asking the same question, you can do this thing called harmonizing, where you can bring together all the different findings and you can group them, which gives you huge data sets, which allows you to make very big statements like, there is higher mental health in this group. When we're asking about sexuality, I'm very interested to see what will happen from the census as to how many people choose that. I think it's societal changes that will encourage people to feel more confident about answering that question. I think providing online is helpful, and actually doing a campaign, which I was very, very keen on seeing, and I don't think I saw enough of it around the census, which is encouraging people to understand that there are the surveys that I'm talking about, your identity is completely protected and you're completely safe to come forward. I hope that answers that for you. That was Amy again. Okay. Amy's come in with an answer. I'd make an educated guess. The risk for student mental health is the same. Perfect, absolutely perfect. I agree with you. I think that there would be very subtle nuance to Amy saying that she wouldn't necessarily expect there to be a difference, and I wouldn't, but I might expect to see if we could ask questions about access to services and access to support networks. I'd like to think that the student population are getting a higher level of that, but whether that would actually be enough to impact on change on someone's mental health, I don't know. It's a complex question. And we'd need to have good enough data that gathers someone's identity as a student at the same time to be able to answer that. But thank you for coming back to me, Amy. And she's trying to make notes. This is getting recorded, so I think, yes, so you should be able to watch it at your and Reese, okay, so that's the final question. I'm going to respond to that as well, because that's a brilliant question. Right. So we are beginning to get a data set now that is a cohort study called Understanding Society. And Understanding Society has been collecting data from young people going up over time. So it's a longitudinal study, sorry, not a longitudinal study, which means that the same people ask questions over time. We are able to start to answer some of the questions around younger people, although we're not actually asking their sexual orientation and gender identity at this point, but we can pick up somebody who's got a particular ID. You can map that each participant's kind of journey. So we might be able to see how things change for people over time, but only once they've identified as LGBT, which would be later on in the series of surveys, if that makes sense. These are the kinds of questions that I'm working on, and that's a brilliant question, and hopefully I've answered everyone's questions fully.
Yeah, thank you very much. If anybody's got any more questions, you can always email or go on Twitter, or just
yes, please do.
Look at all the.
There's my email.
There it is. Thank you very much.